So welcome to Angel Health Academy. Subject Community Health Nursing. Topic for the day is Revised National Tuberculosis Control Program RNTCP Part 2. Revised National Tuberculosis Control Program RNTCP Part 2. I have already uploaded RNTCP Part 1 video with the introduction, global scenario, history, milestones, beginning of RNTCP, goals, objectives, program indicators and phases. The first part video was ended with the pilot phases of RNTCP, and in this video, its second part, I would like to talk about the phase 1 and phase 2 of RNTCP, which includes strategies, activities, organization structure of RNTCP, diagnosis of RNTCP, laboratory network of RNTCP, and new and newer initiatives under RNTCP. So if you have not yet watched the first part of the video RNTCP part 1, please go through that and watch that particular video to get the introduction of the part of RNTCP. Then come back and join for the second part, that is phase 1 and phase 2 of RNTCP. So the phases of RNTCP. Phases is already explained in the part 1 video. There are mainly 3 phases, including that pilot phase that was started in 1993 to 1996. Then that we have already explained in the first part of the video. Then second is phase 1 of RNTCP. The period is between 1997 to 2006. Phase 1 period is also known as DOTS intensive phase. DOTS intensive phase. Then phase 2 of RNTCP, the period between 2006 and 2011. This phase 2 of RNTCP, also known as Stop TB Strategy phase. Stop TB Strategy phase. Then the third phases of RNTCP includes Universal Access or National Strategy Plan phase. So there are 2 National Strategy Plan phase. First is one is control phase and second one is elimination phase. The period of control phase was between 2012 to 2017, and the period of elimination phase is between 2017 to 2025. So let us start the session of phase 1 of RNTCP, that is between 1997 to 2006. This phase was also known as DOTS intensive phase, or this phase is also known as DOTS intensive phase. So the phase 1 of RNTCP was started to expand the RNTCP program in a large scale of phased manner by Government of India, started from 1997. The intention was to cover the entire country, entire states of our country with the RNTCP program by 2005 with the following 2 objectives. So the 2 important objectives of first phase of RNTCP was, first one is to detect at least 70% of the estimated cases of tuberculosis patients, then to achieve at least 80% cure rate among the newly detected sputum smear positive cases. Then the main focus of phase 1 of RNTCP was on ensuring the expansion of quality DOTS services, that is quality direct observation treatment short course services, to the entire country or to the whole country. So the focus of RNTCP phase 1 was ensuring expansion of quality DOTS services to the entire country or the nation. As we have already said, it is a phased manner of expansion of RNTCP throughout the country. The initial 5-year project plan was to implement the RNTCP program to 102 districts of the country, and later strengthen another 203 short course chemotherapy districts. So another 203 districts to be strengthened in the later part of the RNTCP programs. Then by the end of 1998, Government of India achieved only 2% coverage of RNTCP. So by the end of 1998, we have achieved only 2% coverage of total coverage of RNTCP. Then later, fortunately, Government of India achieved 100% coverage, that is 100% countrywide coverage of RNTCP in March 2006. Thus 100% coverage, countrywide coverage is achieved under RNTCP in March 2006 by Government of India. The next is the revised strategies of RNTCP phase 1. There were mainly 6 important revised strategy under RNTCP phase 1. That is, first one is augmentation of organizational support at center and state. Augmentation is nothing but expansion of the or development of the organizational support from central government, state government and to the district government. So augmentation or expansion of organizational support at center and state. The second strategy was use sputum testing as primary method of diagnosis of TB. So use sputum testing as a primary method of diagnosis for the TB patients or TB cases in India. Then third strategy was standardized treatment regimen with the DOTS program. So introduction of DOTS program as recommended by WHO. So standardized treatment regimen with the DOTS. That was the third strategy of RNTCP phase 1. Then fourth strategy of RNTCP phase 1 was ensuring regular uninterrupted supply of the drugs to all the TB patients. So ensuring regular and uninterrupted supply of medicines or provision of DOTS to all the TB patients without any difficulty or without any shortage. So ensuring regular uninterrupted supply of drugs. The fifth revised strategy was training, IEC, operational research and NGO involvement in RNTCP programs. So training for the health personnel, information, education, communication in relation to tuberculosis control program in RNTCP. Then conducting various operational research in relation to tuberculosis control and prevention, and involvement of various non-governmental organization in implementation of the RNTCP program throughout the country. That is training, IEC, operational research and NGO involvement. The last sixth revised strategies of RNTCP phase 1 was increased budget outlay. Increase the budget and financial support to render the RNTCP program or implementation of the RNTCP program throughout the country. So these are the 6 revised strategies of RNTCP phase 1. Let us explain in short about the revised strategy of RNTCP phase 1. So first is expansion of the organizational structure of RNTCP phase 1 at central level, state level and district level, and in district we have one more area, that is at sub-district level. So organizational structure of RNTCP as a central level, state level, district level and sub-district level. At central level, it is under Ministry of Health and Family Welfare. We have a Central TB Division Department or CTD. That is Central TB Division at central level to monitor, to supervise the and coordinate the services of RNTCP program throughout the country. That is especially supervision of the services which is rendered in the state level. So for the coordination and supervision of the all RNTCP programs in the country at central level, we have a Central TB Division under Ministry of Health and Family Welfare. That means Ministry of Health and Family Welfare is directly responsible for the coordination and control and supervision of the all the RNTCP programs at central level in India. Then at state level, under the supervision of Health, State Health Minister, State Health Secretary, and with the support of the Director of Health Services, and presently from under NRHM, National Rural Health Mission from 2005 onwards, Government of India have a support for the implementation of the RNTCP program by two different departments, two different organization structures such as State TB Cell or State Tuberculosis Control Society with the supervision of STO, that is State Tuberculosis Officer, and we have another one organization structure at state level, that is State TB Training and Demonstration Centers with the supervision of the Director of this particular organization, that is State TB Training and Demonstration Centers. So we have two important organizational structure at state level to render the services of RNTCP by State TB Cell or State Tuberculosis Control Society under the supervision of the STO, that is State Tuberculosis Officer. Then we have a State TB Training and Demonstration Centers under the supervision of the Director of State TB Training and Demonstration Centers. At district level, it is supervised together by a district collector or a magistrate. Then we have supported with the district health services under the supervision of the chief medical officer of the district, and we have two organizations at the district. One is District TB Center, that is DTC, District TB Center, with the supervision of the DTO, District Tuberculosis Officer. DTO, that is District Tuberculosis Officer, and we have a District TB unit under the supervision of the medical officers of the TB center, that is District TB units. At sub-district level, we have two organization structure to render the implementation of RNTCP, that is Designated Microscopic Center, that is DMC, and peripheral health institutions such as sub-centers, primary health centers, etc. comes under peripheral health institution to render the services of RNTCP implementation program, and this institution also known as dot centers. So these are the important organization structures in India to render the RNTCP program. So let us discuss in detail about the central level, state level, district level, and sub-district level of the organization pattern of the country to render the RNTCP programs. So first is organization structure of RNTCP at central level. Central level for the implementation of RNTCP programs and for the supervision and coordination of the RNTCP programs of the state level and district level, we have a central TB division under the Ministry of Health and Family Welfare. So a central TB division, CTD, is the department or organization structure for the RNTCP implementation, supervision and coordination under Ministry of Health and Family Welfare or in Ministry of Health and Family Welfare. The program or functions of the central TB divisions under Ministry of Family Health Welfare is supported by the various national committees on TB diagnosis and treatment and various national institutions at the central level such as NTI, NIRT, NITRD, etc. So there are many national institutes and national committees who support and help to coordinate and supervise the function of the central TB division in or under Ministry of Health and Family Welfare. So in short, at central level, we have a central TB division under Ministry of Health and Family Welfare or under the governing control of the Ministry of Health and Family Welfare to supervise and coordinate the services or implementation program of RNTCP at the state level. Second is at the state level, organization structure of RNTCP at the state level. State level, we have two important organizations. One is State TB Cell and second one is State TB Training and Demonstration Centers. State TB Tuberculosis Training and Demonstration Centers. So first is State TB Cell. State TB cell is headed by the State TB officer. So State TB cell is headed by the State TB officer and assisted by Deputy State TB officer. Under that there are many other officials like medical officers, accountant, IEC officer, state assistant, deputy education officer, TB HIV coordinator, etc. Then second organization structure at state level is State TB Training and Demonstration Center. For rendering the training for the health personnel center and rendering the demonstration in relation to TB procedures, we have State TB Training Demonstration Centers. It is headed by a Director of State TB Training and Demonstration Centers, and he is also responsible for the intermediate reference laboratory. Then other officials are microbiologist, medical officer, epidemiologist, statistician of intermediate reference laboratory, and even number of lab technicians also work under this particular organization. So at state level we have two organizations. One is State TB Cell under the official in charge of the State TB officer and assisted by Deputy State TB officer with various other personnels or officials. Then under State TB Training and Demonstration Centers, it is headed by Director and he is also charged for the intermediate reference laboratory, then other officials. So each State TB cell in our country or in the nation will supervise and coordinate the functions of the various organization structure of RNTCP at district level. Then moreover, the overall supervision of the function and program of the RNTCP at state level will be done by the State TB officer. So overall supervision is done by State TB officer in respect to the particular state. Then third organization is at district level. So organization structure of RNTCP at district level again divided into sub-district level also, that we'll discuss later. So at district level we have two important organizations. One is District TB Centers and TB Units. District TB Centers and TB Units. First one is District TB Centers. There are one district TB center for 13 lakh population. So for every 13 lakh population in the district, there is one district TB centers. And in the urban area, especially in the urban area of the district, one TB center for 1.5 lakh to 2.5 lakh population. So in urban area of the district, we have district TB centers for 1.5 lakh population, that is 1,50,000 to 2,50,000 population. There is one district TB center at or each urban area of the district. Then in case of hilly, tribal and other difficult or backward areas, we have one district TB center for 50,000 population. So one district TB center for 50,000 populations. Then the district TB center is headed by district TB officer. Then they are assisted by or they are supported by other medical officers. Then there are many other officials. They are responsible for different functions at a district level, such as the senior treatment supervisor, that is STS, senior tuberculosis laboratory supervisor, that is STLS, senior dot plus supervisor, urban TB coordinator, IT information technology officer, deputy education officer, communication facilitator, driver, etc. So these are the other officials which comes under who function under district TB centers. Then second one is TB units. So there is one TB unit for 1 lakh population. So 1 per 1 lakh population in general, and in hilly, tribal and backward area we have one TB unit for 50,000 population. So in general, one TB unit for 1 lakh population in the district and one TB unit for 50,000 population if they are living at a different tribal area, hilly area and backward area of the district. Then TB unit of the district is controlled by medical officer who is in charge for the TB unit. Then TB control officer, senior treatment supervisor, senior TB lab supervisor, etc. These are the some of the officials who works under the or function under the TB unit in the district. Then both the district TB centers and the TB units will supervise the function of the other two organization which comes under the sub-district level. So let us discuss about what are the two organization to render the RNTP services at sub-district level. So organization structure of RNTCP at sub-district level, we have two important organization. One is designated microscopy centers, DMC, designated microscopy centers. There are one designated microscopy center at sub-district level for 1 lakh population. And if the area is belongs to tribal, hilly area and backward area, we have one designated microscopy centers or DMC for 50,000 population. So at sub-district level, we have a first organization, that is designated microscopy center, DMC. That is in general or plain area, there is one DMC for 1 lakh population. And if the area is a tribal, hilly and backward area, we have one DMC for 50,000 population to render the RNTCP program as a organization structure and administrative structure. Then designated microscopy center is headed by medical officer. Then other paramedical staffs and lab technicians will support the activities of the designated microscopy center. So the staffing pattern of the designated microscopy center includes a medical officer, paramedical staffs and lab technicians. Then second organization is peripheral health institution or DOT centers. So that is nothing but sub-centers and primary health center is also known as DOT centers. It is headed by medical officer, TB health visitor, DOT provider, multi-purpose health worker, ASHA worker and community volunteers. So at the sub-district level, we have two organization structure to implement the RNTCP program, such as designated microscopy centers and peripheral health institution or DOT centers. So in short, organizational structure of RNTCP has 4 levels at central level, at state level, at district level and sub-district level. At central level, we have only one organization structure or administrative structure, but at state level, we have two organization structure. At a district level also we have two organization structure, and even at sub-district level also we have two organization structure. At central level we have only one organization structure or administrative structure, Central TB Division under Ministry of Health and Family Welfare, or in Ministry of Health and Family Welfare we have Central TB Division for the supervision and coordination of the organization of RNTP services throughout the country. So it supervises and coordinates the functions of the RNTCP functions of the state level. At state level, we have two important organization structure to render the RNTCP program, that is State TB Cell and State TB Training and Demonstration Centers. Then at district level, we have district TB centers and TB units, district TB centers and TB unit to render the or for the organization and management of the or administration and management of the RNTCP program at district level. We have district TB centers and TB units. At sub-district level, we have two organizations, that is designated microscopy center DMC and peripheral health institutions or DOT centers. So you can, after studying everything, you can go through with this diagram and you can get a glance of the organizational structure of the RNTCP. So these are the organizational structure of the RNTCP program in our country. So next is the second revised strategies of RNTCP phase 1. Second revised strategy was use sputum testing as primary method of diagnosis. So use sputum testing as the primary method of diagnosis of all TB cases. In relation to the second revised strategy, let us discuss about the diagnosis of tuberculosis in RNTCP, Revised National Tuberculosis Control Program. If a client is suffering from cough for 2 weeks, so if a patient or a person suffering from cough for 2 weeks or cough continues for 2 weeks, that is more than 14 days, then the sputum of the particular client of the patient has to be tested. That is called as 2 sputum smear has to be taken for the microscopic investigations. So sputum microscopy of the person who is suffering from cough for more than 2 weeks has to be tested. That is 2 sputum smears has to be done for the sputum microscopy. So after the sputum microscopy, if the test 1 sputum smear or 2 sputum smear is become positive. So in sputum microscopy, either 1 or 2 sputum smear is positive for Mycobacterium tuberculosis, then the patient is and the person is considered as a smear positive TB. So if the person is having cough for more than 2 weeks, is 2 sputum smears has to be taken for the sputum microscopy. Then if either 1 or 2 sputum smear is become positive for the tubercle bacilli or Mycobacterium tuberculosis, then the person is considered as having smear positive TB. That is the confirmed diagnosis of TB, that is smear positive TB. Then if it is smear positive TB, he has to undergo for the treatment, that is anti-TB treatment with the DOTS therapy. All the smear positive cases, positive TB cases has to be started with the medication administration, that is anti-TB treatment with the DOTS, direct observation treatment short course. So the DOTS treatment has to be continued for 6 to 9 months according to the symptoms of the patient. Then if the test is become negative, that is 2 sputum smear, if it is become negative, that is 2 negative, he has to be given antibiotic for 10 to 14 days. So 2 weeks antibiotic treatment if the 2 sputum smears are become negative. Then again the symptoms of cough is persist in the patient or in the client. So after the completion of the antibiotic treatment for 10 to 14 days, still the patient is suffering from symptoms of the cough or still the cough continues, that is symptom persist. Again repeat the 2 sputum smears for the microscopy, sputum microscopy. Then again if the client is become positive for the Mycobacterium tuberculosis, that is either 1 or 2 of the sputum smears, he has to consider as a smear positive TB. Then his treatment has to be started and treatment has to be continuous anti-TB treatment with the DOTS therapy for 6 months, minimum 6 months. If repeated 2 sputum smears become negative, that is 2 negative, then second test has to be done as a X-ray examination of the chest X-ray of the patient, that is X-ray examination. So if the repeated 2 sputum smears again become negative, the 2 smears become negative, then a chest X-ray has to be taken to confirm any TB in the particular client or particular patients. Then if the X-ray is become negative, then finally it is considered as the patient is non-TB. Patient is not having any symptoms or any Mycobacterium tuberculosis in his body. That is, the patient is declared as a non-TB. If the X-ray become positive for the TB, then the patient is called or patient is comes under the category of, or the person is comes under the category of smear negative TB. And for smear negative TB also, patient has to be started with the anti-TB treatment, that is DOTS treatment for 6 months. So this is about the diagnosis of tuberculosis in RNTCP. So if any person is suffering from cough for 2 weeks, is 2 sputum smears has to be taken and it has to be tested in the lab as a sputum microscopic test, that is sputum microscopy. If 1 or 2 sputum smears become positive, then he will be considered as a smear positive TB. Then he has to give an anti-TB treatment with the DOTS therapy. Then if it is negative, if both the sputum smear is become negative, then he has to be treated with antibiotic for 10 to 14 days. Then again, if the symptoms continues or persist, again repeat the sputum smears for that same 2 sputum smears. If that become 1 or 2 become positive, then also the client has to be considered as a smear positive TB, that is a clear TB. Then he has to start with the anti-TB treatment with the dose. Then if the sputum smears, repeated sputum smears become 2 negative, both tests become negative, then finally the chest X-ray has to be taken to see whether the patient is suffering from any tuberculosis or no. If the X-ray shows negative, then the patient is declared as a non-TB and he is not having any mycobacterium tuberculosis in his body or blood. Then if the X-ray test shows the positive signs of TB, then the patient is comes under the category of smear negative TB. Smear negative TB patients also started with the anti-TB treatment of the DOTS, direct observation of treatment short course. This is about the diagnosis of tuberculosis in RNTCP. So next is the third revised strategies of RNTCP phase 1, that is standardized treatment regimen for the TB management with the DOTS, direct observation treatment short course. It was recommended by WHO, World Health Organization. So it is a most systematic and cost effective approach which helps to increase the treatment completion rates among the TB patients. So with the DOTS, WHO internationally recommended, it is the most systematic evidence-based or scientifically proved treatment and management for the TB patients, that is with the DOTS, and it is a cost effective approach. It is cheap and best in the management of TB patients. That increase the treatment completion rates among the TB patients within 6 months. Anyway, I will upload a separate video in relation to direct observation treatment short course DOTS. So next is about the second phase of RNTCP, the period between 2006 to 2012. The second phase of RNTCP was also known as or also called as Stop TB Strategy Phase. Stop TB Strategy Phase. So let us discuss in short about the second phase of RNTCP between 2006 to 2011. So the aims of second phase of RNTCP was to consolidate, maintain and further improve and sustain the achievements which has been made in the phase 1 of the RNTCP. So consolidate the achievement which is made in phase 1 or maintain that the same effect of the achievement which had been made in the phase 1 and further improve during the second phase also. So to consolidate, maintain and further improve the achievements of phase 1. Then second objectives are same, that is to maintain at least 70% of the case detection rate among the TB patients, as well as to maintain a cure rate about at least 85% among the TB patients or newly detected sputum positive cases. In order to achieve the TB related targets, the target was set up by Millennium Development Goals for 2015. So by 2015, according to Millennium Development Goal, we have to maintain the early detection of the cases of TB, that is 70%, and a cure rate among the TB patient, that is at least 85%. So these were the aims of RNTCP phase 2. So during the period of second phase of RNTCP, that is in the beginning of 2006, World Health Organization introduced the Stop TB Strategy. So WHO, World Health Organization introduced the Stop TB Strategy in 2006. Let us discuss in short about the Stop TB Strategy by World Health Organization. So Stop TB Strategy 2006. In 2006, Stop TB Strategy was announced by WHO, World Health Organization, and that was adopted by RNTCP, Revised National Tuberculosis Control Program. So in 2006, World Health Organization announced the Stop TB Strategy. There were 6 components under Stop TB Strategy by WHO. I have made a small mnemonic here. It is peace everywhere. The first P stands for pursuing quality DOTS. Pursuing means following or continuing quality DOTS. Then second E stands for enabling, helping and promoting the research in relation to RNTCP and Stop TB Strategy program. Then addressing or presenting TB with co-infection with HIV and other MDR, multi-drug resistant TB cases. That is A. Then C stands for contributing health system strengthening. So contributing or helping the health system of the different countries in the world to develop its health system to render the healthcare delivery services, especially in implementing RNTCP programs. that is C. Then E stands for engaging all the healthcare providers in rendering RNTCP programs throughout the world. Then empowering or strengthening the patients and communities in relation to receive and accept the RNTCP program with the DOTS program. So these were the 6 components of Stop TB strategy by WHO. Then second is the initiatives of Stop TB strategy 2006. So many initiatives, measures or steps were taken by RNTCP. Example is developing and piloting the feasibility of national airborne infection control guidelines. So under RNTCP it was introduced about the national airborne infection control guidelines. So what are the measures to control the airborne infection? And second example is developing and piloting the strategy action plans for practical approaches to lung health. Improve the health of the person with the lung diseases and lung problems or promotion of the lung health. That is practical approach, how clinically improve the strength of the lungs among the TB patients. So these were the example for the initiative which was taken by RNTCP. That is in short about the Stop TB strategy 2006. Now let us continue the strategy of the RNTCP phase 2 or design of the RNTCP phase 2. So RNTCP phase 2 strategy, action plans and design almost same as the RNTCP phase 1, but there were some additional requirements added such as quality assured diagnosis and treatment were built in through schemes to increase the participation of the private sector providers. So till that period it was initiated by the government sectors. Now with this second phase strategy, one important strategy was quality assured diagnosis and treatment by the private sectors or with the participation of the private sector providers, and also inclusion of the DOTS plus program. In the RNTCP second phase, it was introduced the DOTS plus programs for multi-drug resistant TB cases and XDR TB cases. That is extensively drug resistant TB cases. So that is multi-drug TB cases and extensively drug resistant TB cases. So these were also included in the as a strategy or design in the second phase of RNTCP. So let us discuss in short about the design or strategy of the RNTCP second phase. So next is the emphasis or design or strategy of second phase of RNTCP. So emphasis of second phase RNTCP or design of second phase RNTCP or the strategy or action plan of second phase RNTCP. There were 7 important strategies of second phase of RNTCP. The first strategy was strengthening the quality of the DOTS programs. So improving the quality of the DOTS services. Then also extend the access or improve the access of the services for all the peoples or throughout the country. So strengthening the quality of DOTS. The second strategy was to provide services for marginalized groups. The marginalized group includes urban slum dwellers, then people who are living in the tribal area, that is tribal people, etc. So to provide the services or access of the services for the marginalized group of people with the TB treatment and DOTS treatment. Then rational use of standardized first line and second line anti-TB drugs for the treatment of tuberculosis. So rational use of, economical use of, or the complete use of standardized first line and second line anti-TB drugs throughout the treatment of TB patients. The fourth strategy was need-based advocacy, communication and social mobilization to increase the awareness of the people about the RNTCP programs and about the DOTS programs. That is need-based, based on the need of the people, need-based advocacy, communication, EC and social mobilization, participation of the people in rendering the RNTCP programs and DOTS services. Then fifth strategy was quality assured diagnosis in detection of TB cases. So quality assured diagnosis and quality assured treatment with the DOTS programs. Then sixth strategy was inclusion of DOTS plus programs. So DOTS plus program is introduced in Government of India from 2007 onwards for the MDR TB cases. So that is multi-drug resistant TB cases and extensively drug resistant TB cases. So that is XDR TB cases. So inclusion of DOTS plus is the important strategy during the second phase of the RNTCP. So inclusion of DOTS plus program for MDR TB and XDR TB. The last strategy was the seventh one was systematic research and evidence building. So systematic conduct of the research in relation to TB control and TB treatment. Then the RNTCP program in India for the evidence-based practice. So systematic research and evidence-based practices in RNTCP and DOTS program in India. So these were the 7 important strategies of second phase of RNTCP. In relation to the 7 strategies, there are 8 important activities of the second phase of RNTCP. So let us discuss what are the important activities based on the important strategies of the second phase of RNTCP. The first activity was increase the access of quality services. So increase the access of services, availability of services of all the people in the country, both in RNTCP and DOTS program. So increase the access or availability of the quality DOTS program and quality RNTCP services for the people throughout the country. The second activity was institutional strengthening. Strengthening all the institutions available in the country at national level, state level and even district level to improve the services in RNTCP and DOTS program. So institutional strengthening. The third activity was strengthening the intersectoral collaboration or intersectoral coordination to improve the quality services of RNTCP and DOTS program. So that is strengthening the intersectoral collaboration or coordination. The fourth activity was introduction of DOTS plus programs in India from 2007 onwards for both multi-drug resistance TB cases and extensively drug resistance TB cases. The fifth activity was scaling up of the state level intermediate referral laboratories, that is IRL capacity. So increase the number, increase the capacity throughout the country about the state level intermediate reference laboratory for the quality detection of the cases. This is the one of the other important strategy introduced during the second phase. So this will be explained in detail. That is scaling up of the or extending the state level intermediate referral laboratories, that is IRL, to increase the quality of the diagnosis of TB cases in the country. Then sixth activity was distribution of pediatric drug boxes for the pediatrics, those who are suffering from tuberculosis. So distribution of pediatric drug boxes throughout the country for the children, those who are suffering from tuberculosis. The seventh activity was introduction of TB HIV coordinator to coordinate the services of the TB co-associated HIV patients and their treatment programs. So introduction of TB HIV coordinator to coordinate the treatment program of the HIV people, those who are suffering with the co-associated problem with the TB. The eighth activity was introduction of urban coordinator and communication facilitator to increase the awareness of IEC program in relation to RNTCP program and DOTS programs in India. So introduction of urban coordinator and communication facilitator to improve the communication or IEC program in relation to RNTCP and DOTS services in India. So these were the important activities in relation to the 7 strategies of the second phase of RNTCP in India. So let us discuss some of the important activities, new activities or strategies of the second phase of RNTCP in India. So the fourth important activities of RNTCP second phase was DOTS plus program or DOTS plus strategy. DOTS plus program or DOTS plus strategy. So this program was launched by World Health Organization all over the world in 2000, and it was launched in India by RNTCP, Revised National Tuberculosis Control Program, during 2007. So the DOT plus program or DOT strategy were launched by WHO in 2000, and in India by RNTCP it was launched during 2007. DOTS plus is a DOTS program that adds the components for diagnosis and treatment of, especially for the multi-drug resistant TB cases, multi-drug resistant TB cases and extensively drug resistant TB cases. So it is a program that had the component that include especially the diagnosis and treatment of multi-drug resistant tuberculosis and extensively drug resistant tuberculosis cases. Thus, it is a programmatic management of drug resistance of TB. So PMDT. PMDT is nothing but it is a programmatic management of drug resistance TB. So DOTS plus is a programmatic management of drug resistance of TB patients. So later, of course, the DOTS plus program or DOTS plus strategy have proven it was a good option or it was a good program for the proper treatment of the MDR TB cases, so that is multi-drug resistant TB cases, especially for the poor people who are residing in rural areas of our country. So it was already proven as a good option for the proper treatment for MDR-TB cases, especially for the poor MDR-TB cases in rural areas of India. So let us discuss in short about the multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis is a form of tuberculosis infection. So it is one of the form of tuberculosis infection that is caused by the specific bacteria which or that are resistant to the treatment with at least two most powerful first line anti-TB medications or anti-TB drugs such as isoniazid and rifampicin. So multi-drug resistant tuberculosis is a form of tuberculosis infection in which the bacteria is resistant to the at least two of the most powerful first line anti-TB medications such as isoniazid and rifampicin. So this bacteria is resistant to isoniazid and rifampicin. Such TB is called as multi-drug resistant TB or MDR-TB. Then let us see what is XDR-TB, that is extensively drug resistant TB. So this is one form of the multi-drug resistant TB. So XDR-TB or extensively drug resistant TB are one of the form of the MDR-TB, multi-drug resistant TB, in which the bacteria are resistant to both the first line and second line medications. Thus it is called as extensively drug resistant TB or XDR-TB. That means it is a rare type of multi-drug resistant TB. That bacteria or this bacteria is resistant to isoniazid, rifampicin, that is the first line of the treatment, plus any fluoroquinolone or at least one of their injectable second line drug resistance. So extensively drug resistant TB are the rare type of MDR-TB, multi-drug resistant TB, in which the bacteria is resistant to both the first line drugs such as isoniazid and rifampicin, plus in addition to that they are resistant to any fluoroquinolone and at least one of their injectable second line drugs. That means in addition to resistance of isoniazid and rifampicin, it is also resistant to fluoroquinolone and at least one of their injectable second line drugs. This is about XDR-TB or extensively drug resistant TB. Then moreover, as per the DOTS plus strategy, the diagnosis of MDR-TB, multi-drug resistant TB, will be made at the intermediate reference laboratories. Thus, as per the DOTS plus strategy, the diagnosis of all the MDR-TB cases, multi-drug resistant TB cases were made into intermediate reference laboratory, that is IRLs. Intermediate reference laboratories that was accredited to perform the both culture and drug sensitivity test against the or to detect the MDR-TB or XDR-TB cases. That means in which year it performs the both culture and drug sensitivity testing to rule out the MDR-TB cases and XDR-TB cases, or to confirm the MDR-TB and XDR-TB cases. So thus RNTCP has initiated the establishment of the laboratory network in a phased manner in India. That means in all the states across the country with the support of the four national reference laboratories. Four national reference laboratories such as TRC Chennai, NTI Bangalore, LRS Institute New Delhi and Jalma at Agra. So RNTCP initiated the establishment of the laboratory network in a phased manner in all the states across the country with the support and with the coordination of four national reference laboratories for the early detection of the multi-drug resistant TB cases and XDR-TB cases. Thus, the fifth important activities of second phase of RNTCP was laboratory network. So, RNTCP aims to consolidate the lab network into a well-organized one with a defined hierarchy criteria for carrying out the sputum microscopy test with the external quality assessment, that is EQA. So, thus RNTCP aims to consolidate all the laboratory network into a well-organized network with a definite hierarchy or protocol or criteria for carrying out the sputum microscopy test with the external quality assessment. So the quality of the sputum microscopy test was will be assessed by the external agency, that is external laboratory, that is external quality assessment. So the ultimate aim of the laboratory network under RNTCP is make sure the quality assured laboratory services. Quality assured laboratory services. Thus, RNTCP was established a nationwide laboratory network such as DMC, that is nothing but designated sputum microscopy centers at district level, and at state level intermediate reference laboratory, that is IRL, and at national level national reference laboratories. So for the quality assured laboratory services, RNTCP introduced or established nationwide laboratory network such as DMC, that is designated sputum microscopy centers at district level, and intermediate reference laboratory IRL at state level, and national reference laboratory NRL at national level. So let us discuss in short about the laboratory network under RNTCP. So structure of RNTCP laboratory network. Structure of RNTCP laboratory network. So at national level, under the supervision or under the guidance of central TB divisions, we have national reference laboratories. National reference laboratories. In each national reference laboratory, there are 3 microbiologists and 4 lab technicians works or functions under contract basis. That is contractual basis. So at national level, RNTCP laboratory network under the supervision and guidance of the central TB division or under the direction of central TB divisions, the organization structure of RNTCP at national level, we have a national reference laboratory. Then at state level, under the organization of the state TB cell and state TB training and demonstration centers, so we have intermediate reference laboratory. So at state level, intermediate reference laboratory. Then at a district level, under the organization of district TB center, we have designated sputum microscopy centers. So at a district level, under the guidance and under the supervision or under the organization structure of district TB center, we have designated sputum microscopy centers. At a district level, depends upon the population, we have a minimum 3 TB units. Then under each TB units, we have 3 DMC, that is nothing but designated sputum microscopy centers. That means there are 1 DMC for, that is designated sputum microscopy center for 1 lakh population, and if it is a hilly or tribal area or backward area, we have 1 DMC for 50,000 populations. So these are the structure of RNTCP laboratory network in India. At national level, we have a national reference laboratory, and state level, we have intermediate reference laboratory, and at a district level, we have a designated sputum microscopy centers. Thus, the national reference laboratory supervises the function of the intermediate reference laboratory, and intermediate reference laboratory supervise the functions of the designated sputum microscopy centers. Designated sputum microscopy centers are responsible for intermediate reference laboratory, and intermediate reference laboratories are responsible for national reference laboratory. Thus, for the external quality assessment, at national level we have a national reference laboratory, and state level we have intermediate reference laboratory, and at district level we have designated sputum microscopy centers to render the services for the quality assured microscopy services for the early detection of the multi-drug resistance TB cases and extensively resistant drug resistance TB cases, that is MDR TB and XDR. This is about the structure of RNTCP laboratory network in India. So let us discuss in short about this national reference laboratory, intermediate reference laboratory, and designated sputum microscopy centers. First one is National Reference Laboratory, that is NRLs. So National Reference Laboratory closely work with the IRLs, that is nothing but intermediate reference laboratories of the state level. The National Reference Laboratory also monitor and supervise the work of the IRLs, that is intermediate reference laboratories at state level, and its activities, and periodically they undertake or conduct the periodic training program for the IRL staff in relation to external quality assessment of the test, and in relation to culture and drug sensitivity test activities. Culture and drug sensitivity test activities. Then the staff of the National Reference Laboratory, we have already discussed. There are 3 microbiologists and 4 lab technicians who functions under contract basis at NRL for the supervision and monitoring the laboratory activities and services of the NRL. Then this staff periodically visit the each assigned state IRLs at least once in a year for 2 to 3 days as a part of the one-site evaluation under RNTCP EQA protocol, External Quality Assessment Protocol. So the second is Intermediate Reference Laboratory, IRLs, Intermediate Reference Laboratory. There are 1 intermediate reference laboratory for the state TB training and demonstration center, or one for public health laboratories, or one for medical college in the respective state or in the respective state. So there are one IRL for state TB training and demonstration center, or one for public health laboratories, or one for medical college of the respective state. The major functions of the IRL or intermediate reference laboratories are: first one is supervision and monitoring of the external quality assessment activities. Supervision and monitoring of the external quality assessment activities. Then second one is laboratory services about the mycobacterial culture services and DST, drug sensitivity test laboratory services. So rendering mycobacterial culture test and DST test at laboratory. The third function is conducting drug resistance surveillance, that is DRS, drug resistance surveillance in the selected states for the early detection of the MDR TB cases and XDR TB cases, that is DRS, drug resistance surveillance. The fourth function is providing technical training. So providing training services to the district and sub-district lab technicians and senior TB lab supervisors. So technical training for all the district and sub-district lab technicians and for the senior TB lab supervisors in the state. Then last function is undertake one-site evaluation, or to conduct a visit for one-site evaluation and do the cross-testing or panel testing to each district designated microscopic centers in the state at least once in a year. So conduct or undertake a one-site evaluation once in a year and do the panel testing for the external quality assessment assurance. So the mycobacterial culture and DST laboratory services is also done by other labs in addition to IRL, that is RNTCP also involves microbiology department of the medical college to conduct the mycobacterial culture and DST laboratory services, and public sector labs, private sector labs, and labs operated by NGOs, non-government organizations, all provide services for providing the services for the drug resistance TB cases and extrapulmonary TB cases for the early detection and treatment. The various services which are rendered by the labs includes sputum microscopy, solid culture certification, liquid culture certifications, line probe assay, that is LPA, line probe assay. It is a molecular diagnostic test which can provide DST result, drug sensitivity result within 1 day. That is line probe assay, LPA. Then second line DST, that is SLD test. Then rapid diagnostic test for the multi-drug resistance TB cases. So last one is DMC, so that is designated microscopy centers. It is the most peripheral lab under the RNTCP network, which serve a population of, in plain area, 1 lakh population. So 1 DMC for 1 lakh population. But in hilly, tribal and backward area, one DMC cover only 50,000 population. Currently, all the districts of our country are implementing the services under DMC and maintaining the external quality assurance. The main test is sputum smear microscopic examinations. So usually it is done in the designated RNTCP microscopic centers, and actually they are located either in the community health center or in the primary health center or in the taluk headquarters hospitals or in the various TB dispensaries in our country. The next is the RNTCP endorsed or declared TB diagnosis. So there are two important endorsed TB diagnosis under RNTCP. One is sputum smear microscopy for acid-fast bacilli, that is done in solid and liquid medium culture test. That is sputum smear microscopy for acid-fast bacilli. Second test is rapid diagnostic molecular test. Rapid diagnostic molecular test, which includes conventional PCR based line probe assay for MDR TB cases and real-time PCR nucleic acid amplification test, that is NAT, N-A-A-T. So real-time PCR nucleic acid amplification test, that is NAT, and other tests. So these are the two important tests that was endorsed or declared by the RNTCP for the TB diagnosis. So let us wind up and conclude the session. The summary of the day, part 2 A session of the RNTCP video, we have discussed about the phases of RNTCP in general, the classification. Then phase 1 of RNTCP, which includes the strategies of phase 1 RNTCP. And in detail, we have discussed about the organizational structure of RNTCP in India and diagnosis of tuberculosis in RNTCP in India. Then phase 2 of RNTCP, in that we have also included a Stop TB strategy 2006. Then strategies of phase 2 RNTCP and activities of phase 2 RNTCP, and in detail we have discussed about the laboratory network of the RNTCP in India. Unfortunately, I couldn't include new and newer initiatives of RNTCP in this video because the length of the video is already increased. So sorry for that. I would like to make a separate video part 2B sessions with the new and newer initiatives of RNTCP. So thanks for watching. Hope this video really benefits in your studies and exams. So if you feel it is really worth and benefits, so please like, share and subscribe my channel, and stay tuned with the Angel Health Academy for the next part of the video of RNTCP. Thank you.